Welcome to the PA is In, the show created by PAs for PAs, where codependency with your supervising physician is a thing of the past, optimal team practice is the future, and physician associate has taken the place of physician assistant as the professional title of choice. I'm Tracy Bingaman, and I'm obsessed with redefining what success as a PA looks like and what it feels like. Here you'll find the mindset shifts, systems, and processes I use to escape healthcare burnout and integrate my work into my life. Work-life balance is a myth, and an integrated life where you thrive professionally, not a balancing act, is the goal here. My mission is to help you to grow into a unicorn PA who loves their job, has abundant energy, time to spare, and work-optional financial freedom. The PA is in. Have you ever been seeing patients and thought, how is this the best method that we can come up with in terms of delivering healthcare to patients? Have you ever gotten to the end of a day of clinic and thought, I felt like I was banging my head up against the wall and I saw so many patients that I wasn't being safe and that I wasn't taking the time with my patients that they really deserve? And also maybe that I wasn't promoting wellness because I'm paid based on the 99204 that I bill or the procedure that I perform in the office. I want to introduce you to Michael Rubio. Michael is a dermatology PA turned health tech pioneer that's going to share with us all of the things that pissed him off enough to inspire him to start his own health tech company. Without further ado, here he is, PA Michael Rubio. Michael, welcome to the show. Thank you so much for being here.
Thank you so much for having me. I'm super honored. I'm very excited.
Tell us a little bit about you and what you do.
Yeah, so it's a great question. The easiest ones are the hardest. So right now I'm a founder of a health tech program, and I'm a PA practicing PA, and I've had a kind of a windy journey to this venture, but it really has been an amazing. It's been one of many surprises. It hasn't been a straight line for sure. But yeah, I live in New York City, and I've been here for about 7 years, and I have a 2-year-old. And we went to the beach today. So it was a great day. She's been scared of touching sand, and we finally crossed that barrier.
Nice. How exciting. Yeah, that's a milestone they don't tell you about in the parenting books, like these things that for me, when my kids learned to pump their own legs on the swings, I felt like that was like life-giving because we could go to the park and they could pump. They don't need me to push them on the swings anymore because they know how to pump their legs. And no one ever tells you that in a book. It's just a thing that they finally figure out how to do.
I love that.
So tell us about your career trajectory. So are you still practicing clinically? And what exactly does it mean to start a health tech program?
Yeah. So, I mean, if I can, I'll start back to at the very start of this, and it all kind of came down to like a moment when I was around 11 years old, when my mom, who's an ER nurse practitioner, bought me my first guitar, and I dreamt of playing in a band. And the one big problem though, I'm terrified of playing with other people and in front of other people. So it's like really required skill to do that. But it didn't stop me. But like fast forward to like 2002 ish, CD comes out called AOL and changed my life. I like discovered the internet, dove me into my like media lab. My teacher taught me how to like use technology to play music with it, and eventually was in one band, and then started moving into another band, and then I was in like many bands as like the creative artist, tech guru, and one thing led to another, and I got my name out there for it. Teachers were like, we think you're pretty good at this, and writing, producing, collaborating, using tech music, like we should go into a career with this. And at the time I was like, I can't do that. My parents are in blue collar work. They're an immigrant family. We are in medicine. I can't be an artist. Like, it's not something I can do. It wasn't stable enough for sure. So I thought at the time. And then I just kind of put it all aside and pursued medicine. And I eventually did my medicine thing, and I graduated from Emory University in Atlanta. And that led me to land my dream job in New York City. I'm from the South, so it was a big, wide open space. And I started working at this rapidly developing dermatology practice as a PA. And I was like loving it. I did this for years, seeing patients. And I felt like I hit a peak, and where I just felt like I was meant to do a little bit more. And the creative push was coming back, because at the time I was seeing like 50, 60 patients. And I was working 10-hour days, 15-minute slots, 2-3 bookings, every 15 minutes. And I was seeing quantity over quality. I was doing this, every day. And my wife and I wanted to have a baby. And I was like, I have literally no time to be a present dad. And at the end of this 5 years, like, I'm still on the same boat. Like, I don't see this, I don't have any ownership of what I'm doing. So I think this all started coming to picture, and I just pressed eject, and I was like, okay, I'm done. I'm going to rework and look for more innovative ways to do care. And that led me into health tech. And then that led me to like write about it. And then I got published. And then that led me to do some consulting. And then that led me to do some podcasts. And ultimately, while I was doing this, I was starting digital practices for clinics and providers, influencers or formal clinics. And that over that time, I've learned like three main things that they all kind of had together. And the first thing I learned from working with these practices and providers is that when we were doing digital practices, is that they all lacked conveniency. Is like illegal for them to be available for the mom of three, juggling family, work, life balance, and to trying to get to her dermatology appointment like during her lunch break. So that was like a really big problem. The second thing that they all lacked was accessibility. And even in today's world, we can get a toaster delivered to us in like 2 hours through Amazon, but like I cannot talk to my provider. So the third thing that they all shared in common and lacked was the timeliness. And this is like synonymous with medicine. It's synonymous with waiting. So it's like we're waiting for our appointment, we're waiting for the provider, we're waiting in the waiting room. And all of this led me to what I'm on my mission now, which is where I kind of create and tap into that creativity again. Is that just simply how providers to profit more by just being effective and impactful digital health providers without compromising on our values or the care that we give our patients.
So are these practices that have a brick and mortar, that are an established practice, that want to have an online presence in terms of telehealth or virtual visits, and you're helping them to kind of bridge that gap?
Yeah. So whenever if anybody comes approach me and said, I want to do telemedicine, it's a very there's a lot of different interpretations of what that word is. And I think the very basic thing is that it's just technology to meet, for how we interpret it, is just how technology meets the patient. So we use it in a communication and a care delivery standpoint. So it comes in all kind of different forms. And so that's the fun part, is really meeting people where they're starting. The end goal of what we try to do is really try to make that gap between a patient needs help, patient gets help, the shortest. So that's how we use the technology and telemedicine. But, it has a very, very broad, definition.
If you're often freezing at work, you need Scrubmates, the insulating underscrub to treat your shivering. Like a bear hugger for providers, these underscrubs will keep you warm even in the coldest environments. Scrubmates offers a sleeveless option approved for the OR, as well as long-sleeved options for those who work elsewhere. They even have a patent-pending pocket for your valuables. No more tying your rings to your scrub drawstrings. Life is too short to have goosebumps all day. A PA-founded company, Scrubmates is on a quest to make your day more comfortable with super soft, functional, and affordable scrubs and underscrubs. head to wearscrubmates.com to fight the hospital freeze. It's interesting. One would think with all of the technology and the fact that we can log on to our chart, our medical chart from our phone as a patient, or that we could access it from home as a provider, that that would make it easier for patients to get a hold of providers. However, that doesn't actually seem to be the case. I find so many providers that I talk to are incredibly overwhelmed by their in basket and the sheer volume of results and messages and communication that is coming at them because patients don't call anymore. They my chart message or they message from the portal. What advice do you have for providers who are like listening to this and thinking, Michael, I hate technology. Technology has made me a slave to my patients, a slave to my in basket, and I feel like I have to chart all the time or be on all the time.
Yeah. Oh no. When I talk, so two different. I tell this story, or if I talk to patients, I get a totally different reaction. I get like, "Oh my god, what you just described would be amazing." And then when I talk to providers, exactly what you just said. Like, I hate messaging people. Like, I don't have time to do what I'm doing. I hate my portal. I hate everything about it. It's the worst thing. My EMR, and so those two things really have to be addressed, and because but the one big thing that the big caveat of this is when we talk about innovative healthcare delivery models, we generally talk about outside of the traditional model, which is I think 85% of all care delivered in the US is through the fee for service model, which is a very interesting model, and it's been around for a long time. But patient comes in, that checks insurance, it's insurance based, and it's very in person fixed. And now COVID changed a lot of those rules, but when we take telemedicine and what happened during COVID, and we try to bend it over backwards and try to cram it into the traditional fee for service model, it doesn't really work that well because you're ending up with the incentive is mismatched. The provider's incentive is not in line with the patient's incentive. And so I think in many ways, telemedicine and the way I talk about it is this innovative new model that kind of goes outside of this fee for service. And so that's where we can kind of play around with. And we've had great success in that. And that's kind of the education around it all. But I feel for the providers because you can't add telemedicine in the way that I'm talking about it in the fee for service model. It starts to break down and it falls apart, which is why we've started doing it less now that COVID, quote unquote, is over.
Yeah. So how are these practices getting paid? If it's not, I call you and I want an appointment and I tell you what my insurance is and you see if you are a participating provider and then we go from there. How does it work?
Yeah. So the first step is like, when we talk about just when you're talking about new innovative ways to do care delivery, and especially for an existing practice, as you mentioned, there's like three steps to it. I would say you don't just start off doing care through it. The first step is like most practices in America just have a phone number that they have. And so when we came to this practice in New York, there's 28 offices in New York, 28 individual offices, dermatology offices, all connected under one brand. And so it's very sprawled. I mean, the 65,000 patients that total they see. I mean, they were getting 1,000 calls a day, and they were missing 30% of those calls because they couldn't get to the calls, or they're overwhelmed, or the calls were taken. So whatever. So what we basically said, let's view the telemedicine component as just support. So there's three main ways to look at this. There's support, there's care, and there's self-serving. And there's three viable models within that in the market now. But when we say, to practices, do you have a support telemedicine function? And, generally the answer is no, because upwards in the 90% of clinics, and this is globally, just have a phone number. And in our industry in general is very behind other industries. And so So when we said, okay, well, if you're getting 1,000 calls a day, you're missing 30% of them, and you just have a phone number for patients to contact you, like that's simple answer one. Let's give them different ways to message you and schedule an appointment. And so this is texting, this is website messaging. And so, my gosh, I love looking at the data over time on this, but within the specific 28 practice, New York City, everybody's wanting instant gratification. We can get, food delivered to us in our door in like 45 minutes. So, it's pretty high expectations especially in New York City, very competitive. So he opened in this. I mean, right now he's been launched for like 8 months, just a website and texting, and he's upwards to 8,000 saved calls that he has now routed. So he dropped 30% call volume, has now captured the people looking to get those appointments by simply opening up different ways. Now that's perfect example of telemedicine in a support form. And when we talk about the care form is when you are then messaging patients and seeing what they're messaging you about. The problem with the phone call is that you're just one-on-one. That message is not recorded or stored anywhere, so you can't really see it. There's transcription errors because our front desk are not medically trained, which is a big problem with the back and forth. And so what we said is, these messages now we can go through them and see what people are messaging, like even calling us. And then you can, go into like the care version of telemedicine and start delivering care to those people in a very specific way. Because you now have a way to talk to them. And then the third thing is self-service. So once you are doing your care over and over and over again, and you're like, man, I keep getting these people asking about this one thing, then you can do a self-service and then say, have triggers and mechanisms in place to, if those aren't working, we can trigger an in-office visit. And that to me is a very lacking thing in the industry now. We have separate models where innovative telemedicine companies only online only, and what happens when the patient needs in-person help, which is a good portion of the time. So yeah, so that's how I would break it down in the three main versions of the word telemedicine.
That's so interesting. So I had an experience maybe a week, maybe 2 weeks ago, where I had to see one of my providers who had told me the last time I saw him, if you need me, don't call, because I am never in the same place and the nurses can never get a hold of me. And sometimes it's routed to the wrong person. Don't call, just message. So I said, okay, I know how to follow instructions. So I typed up this message. Hey, I'm having this symptom. I think we need to test me. Of course, I'm me. So I'm like giving treatment recommendations for myself in the message of what I think I need from a testing standpoint. I think we should adjust my, beta blocker, blah, blah, blah. So I send this message. And I know he knows me well. I am a weird medical case, which is just part of working in medicine, I suppose. And so his nurse calls me, but I'm seeing patients. So then I call her and she doesn't pick up. And then she calls me and I'm seeing patients. And then I call her. And we do this back and forth. We get on the phone once. I ask her a question she doesn't know the answer to. The next day we do it again, of like phone tag of back and forth, back and forth. And I'm like, I have wasted 16 and a half phone calls and an hour of my life that I will never get back to try to get one clinical question answered. And this is not an efficient means of conversation. And essentially, she said this was too much to text. And I thought, this seems like the perfect amount of information to text, because if you had texted me, I could have read it and responded, and then you could have responded, and it would have taken 4 seconds, not 4 days, to get to a conclusion of this communication.
You mentioning a really great point, and that's you're touching on where we're now at in post COVID telemedicine world in the traditional world. I would assume that the person that you're seeing is still in a traditional model, and that is where they're struggling. I mean, like I said, it will always continue to struggle if we continue to work in this model. Now, you asked me like, how do we make money off of this? So, I mean, in many ways, like, how is this a viable, sustainable model? Like, and what we've proven, so our product originally started in New Zealand, which is a free healthcare system. I mean, to say free, but they pay taxes. So, but most people don't pay for, how we pay for it. So it comes out of their taxes and they go to the doctor. So they need an issue. They go to their GP. That's what they call them, which is effectively our primary care. And So they go to their GP, they get their health issues meds, and all prescription medications are like no more than $5, and the system works. So imagine that system, and then we come in with our product that says, you can get access to your doctor or your PA or your MD or your nurse practitioner or whoever, in providers. In New Zealand, PAs is growing, but mostly doctors there. So you can access to your doctor, and you can, by paying a fee, just a direct fee. And now this fee we set it at 49 US New Zealand dollars. And my God, 15,000 members over a course of a year was utilizing our service because they wanted convenience, accessible, timely care in a free healthcare system. So when we were blown away by this, so we were like, oh my God, like America is going to flip over this. And we see a lot of models like this. And, of course, every market is different, and the states are like 50 different markets. And within those markets, there's more markets. So it's a very regional thing. But I think overall, there's a huge gap in our market to where patients have high deductibles, they have no insurance, and they would rather pay money to get access to you, rather than doing all the hustle and bustle of getting an appointment, which is very, very inconvenient for them. And on average, it's like 4.5 weeks, for a PCP provider, especially in New York. I think it's more in other places. So from like that perspective, it's called consumerization. That's another word that we're using more of medicine, but we're taking that and say, can we do care directly to the patient? Like, can the patient pay me money without the insurance, directly? And I'm here to say that that is a very viable aspect. And in fact, looks, a lot of patients prefer it. And I'll give you an example. So when we were in COVID, we started developing more innovative ways within the traditional model. So I did a national poll of people trying different ways. And one way was, $99, you'll get, a visit. And patients were paying that directly without doing the insurance because we weren't sure if we were going to get reimbursed. And so patients were paying $99. When we took it away, patients were calling and saying they were upset because it was cheaper than maybe the copay. Maybe in their mind, it was cheaper than taking a day off of work, driving, paying for parking, taking the kids, the whole thing. So in their mind, it was more affordable to do the $99 to get access to care. Now, so when we talk about in payment models, that's a very innovative way that we could approach it. And so that's kind of what I play around with, is these innovative delivery models to where patients will get directly care from us, from the provider, like, the old days before insurance, and the mess that we're in now within the US healthcare system.
Yeah. It's interesting. My primary clinical position is I work in a private plastic surgery office, but what I mostly do is Botox and filler. So we do cash pay. I don't see any insurance patients. And it's so interesting because I feel the aesthetics industry is ahead on this because we never thought insurance was going to pay for it ever. So we did not have the fee for service model ever. We said Botox costs this much, filler costs this much, a consult is this much, pay and come, or don't pay and don't come. And we're happy to see you. And people come and they give us money. So this does not sound foreign to me. I think if I was coming from an insurance fee for service model, I would think, what? They just pay you and then you call them and then you treat them and then you prescribe things. Like that would feel weird to me. But aesthetics, so many practices in our area have texting for appointments, have texting, you can text your provider directly. And those things are awesome because then the clinician is answering the clinical questions, not the clerical staff asking the clinician, who's then relaying it to the clerical staff, who's then calling the patient and answering the questions on the phone. There's just a lot of potential for things to get lost in translation when that's happening.
Yeah, you grow it to what we are now facing now. I think the best way to talk about the healthcare system is, so I'm from the South, despite my New York hat here. I grew up in Georgia, and I grew up in Georgia, and so I love a little bit of country. I love a little bit of rock. And one of my one of my favorite songs is from a band, very very old band, one of their first albums. It's called Leonard Skinner. I'm sure we all know this, but there's a song called Simple Man, and one of the lines in the song, it says, be a simple kind of man, be something that you both love and understand. And I relate that to the US healthcare system because I both do not love it, and it is not loved as an industry, and I do not understand it. So, and most people don't. And even as me, this is me. I've been in healthcare since I was very like 18 years old, and I still am learning a new acronym, every week it seems like. And I think for me, that's how I approach care is to keep it simple, silly, like approach. And what I found was, and what we found in many ways when we do this thing is, patient has a problem, patient message provider, provider delivers care. Now, in other industries like Amazon, I give you an example of like the toaster. They have put this first. And so one of Amazon's driving models and why it's such a massive company now, I think employs like 1 million people or more. But one of the main things that drives that is the kind of the main ethos behind kind of Amazon, which is what's best for the customer is best for the company. And in many ways, we've lost that within healthcare. And when I was in my traditional fee for service ways and seeing these patients at astronomical volumes, it's quantity over quality in many, many ways. And I was raising flags. I don't feel safe doing this. It's just too much. And, that we've lost it. We've lost sight of that. And when we can put the patient, like what's best for the patient, you start breaking down all of these things and you realize, wow, this is really, really simple. And we just came from a technical standpoint and say we want a platform that makes that as easy as possible for the clinician. Having very much experienced burnout myself, that is a real thing. And if you're not working within a system that you can share your values and deliver the care, it's going to happen. It's going to happen. So it's shocking. It's really shocking what happens when those two things line up.
Have you ever wondered if your malpractice policy is providing you with enough coverage? Turns out that employers' policies protect their interest and not necessarily yours. CM&F Group offers personal liability protection that adapts to your growing, changing responsibilities, including state compacts and allowing for protection for practicing medicine across state lines. From telemedicine to license and HIPAA defense, if it's something that you need protection for, CM&F has you covered. PA students can even enjoy a completely free student policy from your first day as a student until you become a licensed PAC. In a climate where we are hyper aware of charting, wording, covering ourselves, and constantly worried about practicing defensive medicine, you can't leave your liability coverage up to chance. Enjoy the peace of mind, exceptional customer service, and find the best comprehensive coverage that fits your practice at www.cmfgroup.com/the PA is in, or click the link in the show notes. I have often said that the healthcare system is not designed for patient health, but it's also not designed for providers to thrive. It is just simply not a system where the economics or logistics of it means that providers can be taking good care of patients and good care of themselves. That oftentimes we say, oh, we're taking good care of patients within the constraints of the system, but sacrificing our own morals, ethics, health, mental well-being at the altar of a healthcare system that will never love us back. It just won't.
Well said. Well said. And the more and more I've got dived into this, and the more or less conspiracy theory I've become. And I do think at the end of the day, it really, the healthcare system in the U.S. it comes down to like bad feedback loops. There's so much information that's not getting back up, and because it's so complicated, and it's like what, it's so complicated. And that those feedback loops just don't exist. When you just talk to patients and you ask them. Now, a lot of providers, I understand, are uncomfortable with charging patients money, and a lot of providers are, we call them bleeding hearts, and it's, I want to do things for the patient. I don't even want to think about money. I think it's really weird and it grosses me out, and they have a very like that feeling towards it, which I totally get. But I would just say that we have to be aware of what's happening, because us not being aware of what's happening, we have created a system, and this is the US, that is the most expensive healthcare system in all of the industrialized countries. And what's happening now is that, when you talk to people about that, you go, oh, well, well, maybe you pay for what you get is what you honestly get to. You're like, oh, maybe we are the most innovative. We have the best technology,
Yeah, but we have the
and then you
worst
tell them,
outcomes. We have the
yes,
worst
and then you say,
outcomes.
you actually say we have the worst outcomes on that. So you're paying for more and you're getting less, and people are living sicker lives. And that's the healthcare system. And that's embarrassing as a provider. And it's partly one of the reasons I was this close to leaving it. And I was just like, can I be with an industry that literally is just not changing? And a lot of the ways, as I dig deep, is just there's just so much that where it's hard to break through that, because on the flip side of that is the other way of thinking about it, and that one of the big problems with the US healthcare system is that it makes too much money. And so how do you tell someone, stop doing that because you're making too much money? The incentive is really there. So as a clinician, I started getting open to, I'm doing this. My patients were coming back to me for 400, 500, 600, 700, $800 bills that I was doing. And I realized that, man, this is wild. Like, I don't want to be a part of a system where I'm like bankrupting some patient. Now, yes, there's so much to that, I think, but is there a different way? And most of the times, and what we're seeing now is that patients would rather just pay you to money. And so we're seeing this in many of the consolidated hospital systems in these urgent cares that they own in rural communities. They'll say, you don't have insurance, we'll do cash pay. So, you can come and see a doctor at urgent care, $150. And if you pay cash, it's 70% off, right? So this is happening. This is happening in all the clinics across America. What's the problem is that we're not listing those on our websites. And that's what I'm arguing, is that we should just list those on our websites. People will pay you directly, and you will have a sustainable, and you'll be so surprised by your business if you just started doing that. And if you look at other countries that does this, this is what happens. I mean, patients want to have this information, and they will be happy to pay you it. Most patients, I'll say, we're not really addressing the Medicaid, patients, which is a really big part of this. But what I'm ultimately saying is that there's a big population that wants to deal directly with you.
Yeah. And it's interesting because I think as a consumer, we feel protected by insurance, right? We have always been told that insurance stands between you and a catastrophe. They stand between you and your bills. They help to defray the cost. But what we don't think about when it comes to insurance from a consumer standpoint is that means that they're also in the room, right? So I'm the patient, you're the provider, and you say, I think we need to CAT scan your abdomen pelvis. And I say, great, that sounds wonderful. I'm having abdominal pain. I'd also like to know what's wrong in there. And the insurance company says, well, hold on a minute. If you expect us to pay for that, we need you to justify it. We need you to approve it. We need you to go to a specific place. We need, and suddenly that protection feels less like protection and more like control. Like I am now limited in what I can do as a patient because this person's paying.
Yeah, it's why a lot of patients are leaving the allopathic way of doing medicine, and why these self-direct labs are becoming so popular, and why these direct self, like, I'm going to pay for my own MRI. Like, the providers have a lot of thoughts on that for sure. But from the patient standpoint, they feel like they don't have autonomy in the current system, and then match that with like inadequate providers, maybe a whole host of things, and we've gotten this kind of out of control. Patients are just going to get care, but one of the things that we cannot deny is that patients do want more autonomy in our current system, and if you just ask them, they'll tell you what they'll pay for your service. I mean, it's pretty wild. And so it's, and what you mentioned a great point, the insurance. And I'm not here to say that we need to get rid of insurance or anything like this. I just think we really need to maybe rethink what it means. And, this is a big, I mean, many smarter people have written many books on this, smarter than me. A book that came out, Catastrophic Care is one, The Price We Pay is another. I mean, these are great books that address this. But one theme that comes out of that is should insurance cover every single thing that ever we can ever think that relates to healthcare, and then how do we pay for that, and how do we start thinking through this, because these are really important conversations, definitely hard questions, but I think when I come in and it's just a point where patients want more choice, and to your point, and as providers we can provide that.
Yeah. And also, as providers, we come out of school knowing how to practice medicine, but we don't understand how healthcare works. That has been, for me, one of the biggest gaps in my knowledge. Like, I know how to perform the surgery, I know how to discharge the patient. I do not know how that works in terms of billing or coding or insurance or the bill that they're going to get. And I don't know because it's very unclear. And I could do 17 appendectomies on 17 different patients with 17 different insurances, and they would never get the same bill. So even if the patient had a question, I wouldn't know how to answer it or how to even give them the information that they're hungry for, which is why those patients would rather say, I'm going to call up in advance. I'm going to get a price. I know the price. I'm going to pay the price, because no one likes to be surprised by the cost of things that have already happened, right? In healthcare, we treat you first and bill you later.
Or maybe garnish your own wage. I mean, these are very well documented practices that hospitals do to retain their money. It's just like, well, we'll just take your whole wage. And so this is, yeah, you're right. This is a big problem from the patient standpoint, and providers are not getting tossed by this. And so this is kind of like a thing that we are now. It's a thing. It's a really big problem. So, and I think conversations like this, I hope people can start having them, and we can start having these inside the classrooms, as well, because we do kind of produce providers who are built for one type of delivery, and so that's kind of a thing. These are changing. These are changing, but I think ultimately you're absolutely right, and I know myself, nobody's going to like start a health tech company. I'm very like specific and very lucky, to be honest, because I know some engineers, and I'm not claiming that people do know that. But what I'm here to say is that the tech that we created, or that people create in general, it is not going to solve the problem. It is not going to solve the problem. I mean, the tech is very simple, and the technology that we have it currently exists in other markets, like, and so it takes about 30-15 years. I mean, some say 15 years for technology to get implemented into healthcare. A really great example is that EMRs versus appendectomies. So EMRs took 30 years. Appendectomies took like 2.5 years to get fully integrated. I think we're very kind of coming up on the AI. Like, is this something that gets mass adopted quickly, or is this something that takes like 30 years, like an EMR? So I think that's also another question. But I think really when we come to it, and just hopefully this conversation just says, I really want to help people kind of understand that they have another route. There's another route. And, for me, that has allowed me to be a present dad. That has allowed me a flexible lifestyle. I mean, this is a very different way of thinking about delivering care, that is both beneficial for the provider and beneficial for the patient. Um, we've seen that. I mean, this is why Amazon, the Walmarts, the Microsofts, the Googles, they're all trying to solve this problem. And they're not doing that good of a job, because it really is the provider. It's this provider, it's clinicians. It really comes down to our choice here.
Yeah. And what a great reminder for the clinician listening to get curious about the way that things are being done in your practice, and that it's okay and honestly probably encouraged and beneficial for both you and your patients for you to kindly, respectfully question the way that it has always been done, because that's probably not the best way to do it.
Yeah. I mean, one of the biggest things of how to merge, like I got tapped into my creative beginnings. Now I still stayed in medicine and I bring that to it. And it's largely just like, what are my talents? How do I take those skills and apply them to medicine? And honestly, we need more people doing that. A very important vital sign of a US healthcare system, of a functional healthcare system, is innovation. And these are creative ideas that we bring to people. So, hey, I have this good idea. Oh, actually, that's really small. I like that initiative, but maybe, we're working on this. Okay, great. Well, here's another idea. Like, I have an idea of like working with flow patient. I mean, these are really, really needed. And so these are really great positions that you could offer. And this really, there's no wrong answer. Like, so tapping into your skills and what you love about that skill. And, for me, it's music. I love how music makes me feel. I love how we can translate music into many different languages. And I could touch people, through my music, and, it could impact someone in a different language in a country far, far, far away because of what I'm expressing through the music. Like, that to me can absolutely happen through care, like through our healthcare system, and just kind of bringing those things we like about other things into our work. You'll be very surprised of what comes out of that. So from a clinician, yeah, I'm not saying you need to start a health tech company. I'm just saying that you really maybe if you want to start somewhere, you could start. Now, for those who do, especially those who have like an actual social media following, my gosh, there's so much potential there. That when if you were to curious, we work with a lot of influencers. If you poll your base, like your followers, how many of you guys would be interested in like me being your provider? Oh my gosh, you'll be very surprised on what you find. And that is just an eye-opening experience, because we're now moving into a way where 9 out of 10 people in America have a cell phone. There is, upwards of 90% of people have an EMR, and the federal government is now accessing, mandating that we're starting like sharing information now, and moving into like specifically to PA licensure, where more states, you get licensed in one state. Well, that means you're licensed in 8 states or potentially 50 states. So, you could start a telemedicine company if you were brave enough in all 50 states one day, very soon. So this is like, these are very real questions that are happening right now. So that part there was the part of that I got excited about. And anybody who works with us, we wanted to make sure that the technology didn't adhere, like work for the provider for sure, because we know happy provider equals happy patient. And so that always, that is one of our guiding principles there too.
Yeah. Yeah. Awesome. What a great conversation to sort of get those creative juices flowing and just remind everyone that there are great, incredible, awesome alternatives to the way that it has always been done. So, if people want to learn more from you and find out about this platform and software, where can they go to connect with you online? Where can they go to find out more?
Yeah, so like the platform that we design is called Well Revolution. This is our consumer brand, and all that we're really trying to do is create flex. It's a two-sided marketplace: providers and patients. For the providers, we're trying to create flexible work-life balance and ownership. Like, so that's a big thing that PAs are really not able to have, and that ownership is comes in a lot of different forms, but. So the ownership, and then we try to match them with patients who want convenient, accessible, timely care. So that's the match. And that whole thing runs off of our technology that we developed. And so clinicians can either join Well Revolution as a provider, or they can use the technology in their private practice. So that's kind of how it all boils down. But really, at the end of the day, it's trying to give the technology that really is like kind of all encompassing to people who want to maybe do something a little different, or who have direct, who sees this. So right now, I think we're growing. We're a growing bunch, especially the PAs. When we talk about PAs, and I'm a PA, obviously, it is one of the most misunderstood, undervalued professions in all of healthcare, and we're a growing bunch. And I've legislated at the state level. I've done legislation at the national level. I sit on communications teams at my state level and national level, and I love communications because I hear all the scoops. And you'll be surprised of how no one knows what a PA is. And you have to bend over backwards to try to explain it to them. And that is just, it is ripe. PAs are ripe for telemedicine opportunities, because we're frontline workers, and we know when to refer. We're team based, so we know when to refer. We know this. So my gosh, I think the future for PAs and telemedicine and digital health, and just more for opportunities for us, is just through the roof. And we're seeing companies like Amazon really understand the value of PAs, because if you look at their leadership team who does telemedicine, they're mostly led by PAs. So PAs and NPs, I'll say that too, for all the other clinicians here. But I think the NPs have done a great job of advocating for themselves, and lobbying, and they double us in number. And so kudos to NP. My mom's an NP, and they fought the fight. And so I thought there's a lot there that we need to do a lot of education around.
Awesome. Well, Michael, thank you so much for coming on the show and sharing your passion and creativity with us. It's been a pleasure.
Thank you so much for having me.
I love when an episode reminds me that the way that we've always done something is not the single best way for this thing to exist in the world. That there is room for improvement in the way that we're delivering care, and there's room for improvement in the way that patients experience that care. Any technology that intersects a world where a provider has more autonomy and ability to take great care of patients, but also where the patient has better access and more availability of the services that they need, is a great, great place to be in my book. Thank you, as always, for tuning in to another episode of The PA is In. This PA is out. Congratulations, you've just joined an awesome club. By listening to a full episode of The PA is In, you are officially on the Unicorn PA team. Welcome aboard. What most team members do is they subscribe to the podcast, because that allows them to automatically get the latest episode of the show. The life of your dreams exists on the other side of taking action. Keep making small shifts and keep getting better. Your life will improve, your career will soar, and you will have the confidence you need to create your own success. I will see you in the next episode. This PA is out.